And I really appreciate everyone joining us here in person and also through our live cast through Facebook Live. And this is the fourth of and final roundtable as part of our Advances in HFG series. We previously had a roundtable on domestic resource mobilization, strategic health purchasing, and health financing strategies. And so today we're going to be looking at the hot topic of health insurance. And even those of you who work domestically, I think you'll find it some interesting relations to even our own domestic health insurance challenges. So I'd like to show you we'll be beginning with a look at the 5 lessons that we've learned as a project, and then take a deep dive on 3 country experiences: India, Ethiopia, and Indonesia. For those of you watching virtually, please, we really encourage your participation. We have Alina here who will be monitoring the Facebook Live, and you'll be able to submit comments and questions at any time. And we're also recording the event, and that will be available on our website. So I would like to first introduce Nathan Blanchette, who will be moderating the panel, the roundtable. He's a senior economist on the HFG project with Results for Development. He has 15 years of experience advancing public health and education in Africa, Eastern Europe, and Asia. He's currently leads the design and implementation of national health insurance programs and other means of achieving universal health coverage in low and middle income countries, with a focus on primary health care and integrating vertically financed and private health services into public financing systems. So without further ado.
Thank you. So thank you very much, Catherine, and good morning to all of you, both here in the room and online. It's a great pleasure to be here and talk about one of my favorite topics along with some of my favorite people. So really looking forward to the morning. We're a small group and have a small sample of experience here. You in the room and online are a larger group with even more experience. So we really do hope that you'll be thinking through the things we say and sharing your own experiences, questions, comments especially. We'll have plenty of time for that. So we are focusing today on expanding coverage through health insurance. So why is that? As many of you I'm sure know, health insurance is certainly not the only means of pursuing universal health coverage and expanding access to health services, but we're focusing on it because it has seen a very rapid expansion in low and middle income countries, really over the past 2 decades, and perhaps even more rapidly over the lifetime of the HFG project in the past 5 years. So we're seeing more and more countries going to various types of insurance as a means of providing financial risk protection, increasing access to quality care, and generally pursuing universal health coverage. The HFG project has supported efforts to expand coverage through insurance in 9 countries, which you can see on the map here. So Botswana, Ethiopia, Ghana, India, Indonesia, Namibia, Nigeria, South Africa, and Vietnam. Very different contexts and lots of different types of schemes. And the experience that some of us will talk about today comes from experience working with our partners, governments and non-government partners in those countries. Throughout the lifetime of the project has published actually several different documents on this topic. So Catherine mentioned the reason we're here this morning is to launch the last brief in the HFG Advances series, which covers this topic. But there are also others that I want to do a brief plug for, and I have visual aids for the plug. So here is the brief that we're, well, let me start chronologically. In 2014, there were several case studies done on on Ghana, Senegal, and Ethiopia's experience, particularly transitioning from community-based health insurance schemes. So here's the one on Ghana, and Ghana's transition in the 90s CBHI to the 2000s national health insurance. We also just in the past 2 weeks, the project published a special edition of the journal Health Systems and Reform with 9 different articles documenting some of HFG's experience, and some of that did deal with insurance expansion. And in fact, one of the case studies from India that we'll hear about this morning from Gina is in that article. And then finally, we have today's brief. So if anyone here in the room would like to glance at these hard copies, happy to share those, and they're also available online. Okay, so what I will do to kick us off is just give a fairly brief overview based on the most recent brief that I had the pleasure of co-authoring with Hailu Zelulu and Andrew Wan. And this brief and what we're going to talk about today really focuses on this central question. What are, as we reflect on our own experiences, things we've read, things we've worked on, reflecting on that past and thinking about future expansions, what are a few key lessons that policymakers and their partners should embed in future efforts to expand coverage through insurance? So if you're in the audience, I'd really like you to keep that question in mind this morning. We're going to share some thoughts on it. I know that all of you have your own thoughts on it, and I hope that I might be able to turn to the audience toward the end of our session and ask you to kind of share your own things. We're going to tell you some lessons. You may agree with them or disagree with them or have things that you would add to them. So I really hope you'll be thinking about that and prepared to volunteer some of those thoughts at the end. Okay, so I will be giving an overview of the brief, and then following that we will dive a little deeper into 3 different country experiences, country case studies, and we're very privileged to have our panelists with us this morning to speak about that. I'll give you more details on their backgrounds a little bit later, but let me just first say that we have Gina Holtz, who's a senior health insurance specialist with Apt Associates, Hailu Zelulu, health economist with Apt Associates, and Laurel Hatt, a senior health economist with Results for Development. Okay, so when Hailu and Andrew and I went to write a brief sort of documenting some of HFG's lessons on expanding coverage through health insurance, we canvassed various staff that had worked on projects, thought about our own experiences, and we really tried to find out which lessons about this topic were really rising to the top. And the 5 that you see here are the ones that rose to the top. These are the things that if we had to point out several, few key things, again, for policymakers and their partners to embed in their future effort, it would be these. So let me just give quick illustrations for each of these 5. I've done most of my HFG work in Ghana. I've worked in Ghana since around 2009, actually. I've been heavily involved studying and working with Ghana's national health insurance scheme there. So I'm going to use that to illustrate these 5 points. So the number 1 lesson is that expanding coverage through health insurance is as much a political process as it is also a technical process. This probably won't surprise or seem unfamiliar to many of you, but we find that this is a lesson worth reminding people of because it is one that tends to get underappreciated or forgotten in the rush of designing projects and programs. So anytime you are changing the way money is raised to cover health services, the way money is paid out, the authorities that providers have or purchasers have, you of course are dealing with changes in the distribution of power. You're affecting how much money people make. You're making changes in something that is quite an intimate part of everyone's lives. These are some of the reasons why really all health reforms are quite political. And we have found, even in very recent experiences, that the political factors tend to be underappreciated and can really thwart some reforms. The illustration from Ghana, and what you see a picture of here, is when Ghana's national health insurance scheme, in facing some sustainable financing challenges, started to pilot a new way of paying primary health care, that of capitated payments, where providers would be paid a set fee per member enrolled with them rather than a fee for service. This is a very complex technical challenge to pull off, but it's also quite political. And in Ghana's case, they chose to pilot this in the stronghold region of the opposition party. And partly for that reason, though not only that reason, this resulted in very swift and strong opposition from providers and civil society. There was immediate campaigns against it. The Ghanaian media is quite active. There was a campaign that renamed capitation into decapitation and talked about it being the death of the Ashanti region. So this is a very powerful illustration of how failure to fully address and anticipate some of the political challenges can thwart a reform. This pilot had to be suspended, and now the current government is re-examining the approach, still viewing it as a good way of paying primary health care, but wanting to take a much smarter approach to the politics and the technical challenges, which I'll actually touch on a little later. Lesson 2, in addition to all the health financing issues that many of us health economists like to concentrate on most, there are very important institutional arrangements and organizational capacities that are needed to start up or expand coverage through insurance. There are new functions to be played. There are capacities that often do not currently exist in countries. These need to be built up. And these kinds of operational and organizational issues are just as important as things like getting the incentives right through payment mechanisms. So again, in the Ghana case, number one, we saw in the launch of the National Health Insurance Scheme that they had a particular institutional arrangement that allowed them to launch the NHIA virtually overnight on a national basis. And that was because Ghana had previously decentralized and had quite well organized district authorities. They were able to invest in those district authorities and essentially assign them the responsibility of starting up a district scheme. So virtually overnight, there was at least something in place, an authority in place with some responsibility, a way of channeling money that allowed them to open up 145 district schemes. However, then over time, they found that the central authority in the National Health Insurance Authority really began to see a lot of challenges. Claims processing was decentralized to those districts where there wasn't the capacity to do that kind of function. They had not done that before. And ultimately in 2012, they re-centralized authority in the center and have been growing the capacity to do everything from claims processing to membership enrollment to monitoring problems and adjusting over time. And they're still sort of on that journey. Lesson 3, coverage of the poor especially cannot happen without the government. Another lesson that may be quite familiar to all of you, but it stands out perhaps most especially in the case of when we're discussing community-based health insurance schemes. So even community-based health insurance schemes that are meant to be centered in the community, we find that there's an essential role for government in designing the scheme, perhaps most importantly in financing and subsidizing the schemes in order to cover the poor, and in constant monitoring and management of those schemes. And we're going to hear two contrasting stories about this today. Very briefly, the story in Ghana is that Ghana experimented with community-based schemes throughout the 1990s. They had about 140 at the end of that phase, but they only ever covered around 1 or 2% of the population. When the National Health Insurance Scheme was started and there was centralized funding raised by the government through a value-added tax, the result was quite different. In just a few years, they had reached 40% of coverage. We'll hear more about this kind of story from Hailu in Ethiopia. Lesson 4, don't forget the supply side. I would say that the global movement to universal health coverage was strongest and started by concentrating most on the demand side and the focus on financial risk protection. Over the past few years, I think you've seen more and more actors in that UHC movement realize the equal importance of investing in the supply side so that you make sure that the new demand financing coverage that you're offering is really meeting accessible and quality services so that people actually have the access to facilities that they're offered, that human resources for health are available and of high quality, and that the services that are promised in a benefits package are actually available. These things, given the circumstances in low and middle income countries, often take quite large investments, and the sequencing between the supply side and the demand side is challenging and quite important. In Ghana, again, the example from their capitation pilot was, this is one of the technical challenges, they did a provider mapping exercise at the same time and actually found that only 23% of their primary healthcare providers in that region had the capacity to provide the full package that was meant to be provided under that capitated payment. And they did not have any organizational mechanism to have an alternative, such as a network of providers that could refer to each other. So in addition to the politics that I mentioned previously, in the future, Ghana needs to tackle that challenge, and it may mean coming up with some new organizational solution to network providers. Lesson 5, expansion requires intentional and iterative learning and adaptation. So the story here is that effective health insurance expansion really is a very complex task to do, and it is one that has to constantly adjust to changing conditions. If you think about the populations you're trying to cover, those are constantly changing. Their health needs are changing, and they're physically moving. The technologies and services that are available are constantly changing, some going out of favor, some coming into favor. Costs and the revenues from whatever revenue sources that are being used are constantly changing. All these things, there needs to be the capacity to monitor those and continually adjust to them. So this is one of the reasons why people say that UHC is not a destination, it's a journey. That even countries that have reached universal health coverage must still be constantly iterating and adapting and expanding coverage. So in Ghana, you see pictured here one of my favorite friends in the Ghana's National Health Insurance Authority, Mr. Collins, who is the deputy director of their membership directorate. And what he's viewing there is a dashboard that has helped tracking various indicators on membership, which is a capacity they now have, but certainly did not have in the early years of NHIA. So they are really on a path from being a very passive, just payer of claims that were coming in to a much more strategic purchaser. And we'll hear much more about this from our panelists. So those are the 5 lessons that really rose to the top as we canvassed our HFG colleagues and experience. And as we look to the future, they really point to these recommendations that we would make to future efforts. So these are integrate political economy analysis and strategy alongside all the technical work that gets done. Be sure to conduct legal and organizational analysis and build the capacity for new functions. Make sure that you're engaging the government, who are really essential to lead and often subsidize these efforts. Don't forget the supply side means that we really need to align benefits with the supply that actually exists today, and to the extent that it is not satisfactory, invest in improvements for tomorrow. Finally, monitor, monitor, monitor. Really this never-ending path toward universal health coverage, build systems that are able to learn and adapt as conditions change. So that wraps up the overview of our brief. And we will now turn to our panelists. And let me introduce our first speaker, is Gina Holtz. Gina is a senior health insurance specialist for the HFG project, and she has more than 25 years of experience. She provides technical assistance on private sector, health financing, and health system strengthening projects, including insurance and universal health coverage and public-private partnerships. Previously, she was the chief project manager of the International Labor Organization's Impact Insurance Facility, where she launched an innovation program that awarded and tested approaches to make quality insurance products accessible to poor households in developing countries. So the wealth of experience on our topic for today, and she'll specifically be sharing with us some experience from India. Thank you, and welcome, Gina.
Thank you, Nathan, and good morning, everybody. It's a pleasure to be here. I'm going to talk about the experience in India today, and the work that HFG has done in health financing in India has focused on research and advocacy to inform the expansion of health insurance. HFG India has published a series of papers on factors that affect the coverage, in particular of the urban poor in India. And we focused on insurance programs, both government and private, and also the role of primary care. A summary of our research is included in the special issue of Health Systems and Reform, as Nathan had mentioned. And I also want to acknowledge that this work was led by HFG India's health financing advisor, Professor Ramesh Bhatt, along with my colleague Carlos Avila and me. So the lessons that Nathan outlined rise to the top in India as well. But I wanted to just kind of build on that last lesson about innovation, and is the mic on? Oh, okay, so carry on. Okay. So building on this idea of the importance of iterative learning and adaptation, I also wanted to mention the importance of innovation. So innovation really goes hand in hand with learning and adaptation. But certainly in India, it's a place that's teeming with innovation, whether it's to come up with a healthy and sustainable way to wash your clothes or to tackle a much-needed health reform. So the major impediment for India to make progress toward reaching UHC is its low spending on health. India spends less than 2% of its GDP on health, and it ranks at the bottom worldwide. Consequently, it relies substantially on out-of-pocket spending. About 2/3 of total health expenditure comes from people's pockets, and the majority of that goes to buy outpatient services. For outpatient services, the majority of out-of-pocket spending, in turn, is directed toward obtaining services in the private sector. So low government spending is a root cause of both poor quality health services in India, and as well the implications of up to 60 million people per year being pushed into poverty as a result of healthcare costs. So India covers about 42% of its population in some form of health insurance. Most people who have insurance are enrolled in a government-sponsored scheme. There are upwards of 30 schemes across India. They serve about 273 million people. The most notable is RSBY, which has been the Indian government's flagship program for the poor, flagship health insurance program for the poor since 2008. RSBY has really been a front runner in terms of using technology and specifically biometric cards to create a paperless, cashless system that it scaled up rapidly. It today serves about 140 million people, and they have access to more than 10,000 public and private hospitals across the country. The main limitation of the government-sponsored schemes across India, including RSBY, is that it doesn't cover to any full extent outpatient services, and it doesn't fully reach the people it's intended to reach. So urban dwellers represent about a third of India's population, about 438 million people. The important thing to recognize is that an additional 250 million are expected to pour into the cities in the next 12 years. 2/3 of Indians work in the informal economy, including in cities where manufacturing and the construction sectors draw many migrants. And we estimate that as many as 100 million people have migrated to cities for work, making up as much as 40% of the population of some of those cities. People in urban areas spend more on healthcare. So the figure that you see here shows that out-of-pocket spending in urban areas, which are the orange bars, is higher than in rural areas, shown in blue. Furthermore, the out-of-pocket spending in urban areas is rising faster than it is in the out-of-pocket spending in urban areas is rising faster than it is in urban areas, nearly twice the rate. NCDs now make up 60% of India's disease burden. And unfortunately, it's the world capital for diabetes. The prevalence of diabetes is more than twice as high in cities as it is in rural areas, and accidents, which contribute to 12%, an additional 12% of the disease burden, occur more frequently in cities. Urban residents also tend to be excluded from social protection mechanisms more than their rural counterparts. We estimate that about 18% of people in the cities have some form of insurance. The urban poor is a tough number to estimate. The best number we settled on was about 100 million. This is a population that's less likely to be covered by insurance. About 10% of them will have some form of coverage. They're vulnerable to health and economic shocks, with diseases like diabetes being even more prevalent among lower socioeconomic groups. So, in response, India is expanding health coverage through innovative initiatives on the supply and the demand side, and I'll talk about a few of these. Many of them are now beginning to focus on primary care. So one example is being led by the National Health Mission, which is India's largest public health program. The NHM is setting up urban kiosks in the state of Punjab, like you see here. These kiosks provide very basic primary health services to slum dwellers. The NHM is setting these up, and then the ongoing operating costs of the kiosks will be funded by a tax on construction. Another initiative that's being sponsored by the Delhi government are the Mohalla clinics. It was started in 2015. They provide a package of primary care services, comprehensive package, and they're paying private doctors to deliver that care through a capitation mechanism. Mohalla Clinic started with an ambitious plan to open 1,000 clinics very rapidly and got off to an impressive start. And they served 1.5 million clients in less than a year in 2016 with just 110 clinics operating. But since then, the expansion of the clinics has stalled because of some disputes around getting the land and procuring the land in India. So there are administrative and legal bottlenecks now. On the demand side, this year the government plans to launch the National Health Protection Scheme. This builds on some of the innovations that have been piloted and scaled up under RSBY and other schemes in terms of using technology and also some of the institutional and funding arrangements. It also ambitiously targets 500 million people, many of those who are currently not covered, and at the same time aims to expand service coverage and increase financial protection. It will be overseen by a separate agency called the National Health Protection Mission Council. In parallel, it continues to be this sort of chaotic environment. Regulations are promoting new pilots and product innovations from private providers of insurance. The regulator in India has required for a number of years that private insurance companies contribute a portion of their profits toward serving underserved populations. So just to summarize some of the kind of takeaways that come out of the body of work that HFG has done in India. I think last August, HFG and a USAID partner, the Partnerships for Affordable Health Access and Longevity, hosted a consultative meeting in Delhi to discuss options to cover the urban poor and to expand access to primary care. Some of the main takeaways I reinforced the lessons that Nathan has outlined that are really cross-cutting. The first is that expanding coverage requires innovation to develop products that are relevant and affordable for people who aren't insured today. Products have to be simple to understand, simple to obtain, simple to use, and they have to provide tangible benefits so that clients will value them. The second point is that products have to be affordable. And so, as we've noted, one of the key lessons is that government subsidy is required to expand coverage and to provide, to reach the poor. Third point, it's simply not enough to cover hospital services. So insurance schemes need to expand coverage to include primary health care in order to reduce out-of-pocket spending and to encourage better and more efficient use of healthcare services. And as we've noted, it's important, you cannot forget the supply side. So at the same time, the quality and the access to those primary healthcare services has to be expanded. And two final points. Government, through public-private partnerships, should continue to draw upon the social capital of community organizations and the technical know-how of private insurers and technology providers to perform functions such as awareness raising, enrollment, information systems, and so on. Private programs, for their part, need to complement the expanding government programs. And then the final point is simply to keep pushing the frontier, which means to become more efficient. And this means to use more technology and to improve the effectiveness of strategic purchasing. Thank you very much.
So stay here for a second, because I'd like to ask at least one follow-up question.
Okay.
Should I use the second mic or just?
Please do. Yes.
We have it? Okay. Is that on? It's okay? So, Gina, thank you very much. And I'm going to use my moderator privilege here to ask just at least one follow-up question I'm curious about. So I'm not an India expert by any means, but I think, and I think a lot of people think, when they think of India's health system, they think of the very large private sector, very robust private sector in India, and I believe quite high reliance on privately provided health services. I noticed a couple mentions of the private sector in your presentation, but can you say a little more about what the private sector's role currently is and how that works in some of the insurance schemes?
Sure. Maybe kind of two different angles. The first is that private providers, as you've brought up, Nathan, are an important source of care in India. So, and this is in part a response to the failure of the public system to provide quality services that people demand. Private providers give people choice and they can relieve pressure on the public system, but at the same time, if they're not participating in these programs, they drive out-of-pocket expenditure and they contribute to financial hardship. The quality of private providers is also largely unregulated. You can get world-class healthcare in India, but also a quack on the corner is unqualified and is delivering services to many people. So better quality in the private sector is by no means a guaranteed thing. But secondly, India really stands out as a model for how government-sponsored schemes can leverage the assets of the private insurance sector and the private sector writ large. RSBY and other programs have outsourced different aspects of their insurance programs, ranging from risk management to some of the operational functions like claims processing. I think this is one of the enablers for a scheme like RSBY and some of the large state schemes to scale up as rapidly and to be as large as they have. And there's also a precedent for some states to start with this model. This is a quick way to enter, but then to transition when they build their own institutional capacity to a state-owned trust, which then becomes the sort of owner, the full owner and operator of that scheme.
Great.
Okay.
Thank you. I think we have time. We'll do maybe one question right now from the audience. Then we'll move to our next panelists, and we'll have a much more lengthier, robust Q&A discussion after the three. So can we go here with one question?
Thanks very much. Bob Pride, HFG Project Director. On India, thank you very much. Great presentation. I was out there last August in the discussions, and it prompts me to ask a question because we had a fantastic panel. In fact, we had the chief executive for the biggest insurance industry company in India on the panel. And I was very impressed about their knowledge of public health and the challenges in India. But also, he made a point about they were, the health insurance is expanding 18% per year. It was a massive thing going on, huge demand for this. But he made the point that someone needs to invest in the infrastructure of public health. He actually made that point. And I was interested, you talked about a construction tax there. And I wonder if you could say just a little bit more about that.
Thanks, Bob. So I think, this is maybe a good example of how the supply side and the demand side the interventions can come together and complement each other. The urban kiosks are a fairly new venture, and they're in the state of Punjab right now. So I think it's one innovation that's being tested, and the idea of using taxes on new construction is, I think, one way to solve one of the main problems, which is the ongoing operating costs of these clinics. They're also designed to be, they're very basic structures, and they won't cost a lot. So that's another sort of, I think, approach, is to make them really efficient and very focused on providing the really essential services that people struggle to get otherwise.
Great. So thank you very much, Gina. And we'll go to our next presentation. But please, if you have more questions for Gina on India, make a note of them, and we'll come back at the end. Thanks.
Thank you.
Okay, so we are going to move from India to Ethiopia, and we have a fantastic panelist with us today to speak with us about Ethiopia's experience. I'm pleased to introduce you to Hailu Zelilu, who's a senior health economist on the HFG project with Apt Associates. Hailu has over 25 years of experience across a range of development activities, and has specific expertise in designing and implementing healthcare financing and health sector reform. He'll be talking with us today about Ethiopia, where he has extensive experience, has been a civil servant in the government there, and has also recently led the implementation of a major healthcare financing reform there. So please welcome Hailu. Thanks.
Thank you, Nathan. Thank you for the introduction, and thank you all for coming for this session. My presentation will focus on two areas. First, I will give you the context on community-based health insurance in Ethiopia, and then I'll focus on 3 of the 5 lessons, because the 2 lessons are covered by Nathan, and also especially lesson 5 will be covered by, it was covered partially by Gina, and then it will be covered by Laurel. Otherwise, all the 5 lessons are very relevant and important for Ethiopia. So the lessons I will focus are the importance of the supply side and the role of government in community-based health insurance, and also the importance of organizational arrangement and capacity on health insurance. To give you the context, the health financing landscape in Ethiopia looks like the bulk of the money, as you see it from the right side, is coming from donors. It accounts 36% of the spending. But also households are covering the significant portion of the spending, which shows health spending for households can be catastrophic in most cases, and the rationale for introducing insurance. Government spending is 30%. it has substantially grew from the previous years, but still it's far from what is required. When you see the trend in terms of spending, it has been steadily growing, but still, as you can see, the per capita spending in Ethiopia is only $29 in 2013-14, which we have the most recent national health account. So it's far from the WHO recommended around $60 per capita spending for low and middle income countries like Ethiopia. So around 2011, Ethiopia embarked on launching community-based health insurance. And the purpose of that was, as you can see it, as you saw it earlier, the per capita spending is very high. And Ethiopia is a predominantly agricultural, informal economy. Over 80% of Ethiopians are dependent on the informal sector. So the CBHI schemes were designed, one, the membership, they are district level schemes, which household size of around 20,000, which means a population of around 100,000 overall. The membership, when it was designed, it's at household level. It's not individual enrollment, but it's rather household-wide enrollment. And it was piloted in 13 districts in 4 regions. And to give you the context, Ethiopia has close to 1,000 districts, and the piloting was done only in 13 of them. And by the end of the pilot, which was end of 2013, we had coverage of close to 160,000 households and a population of around 700,000. So as I mentioned, the scheme is at district level, but also there are village level structures, more of using the government structure in connecting the CBHI schemes with the village level communities, like on enrollment, sensitization of communities, contribution collection, and other things. The CBHI schemes, they don't have their own structure at village level. We call them Kabbales in the Ethiopian context. But they use the government structure and also the health system structure there. We have the health extension program at village level. So right now the coverage has reached, following the evaluation of the pilot, Ethiopia embarked on a scaling up. So the policy decision was to scale up community-based health insurance nationwide because the result from the pilot was very positive, and the government decided that an HFG project helped evaluation of the pilot and then designing the scale-up strategy and the scale-up plan. So now the coverage has reached almost 500 districts. Most of them, they already have functioning schemes, and others are developing on the community-based health insurance. Over 300 million households are already covered under CBHI schemes, and the total population of 19 million people are covered. I think the basic features, the membership I mentioned, the benefit package, they include both outpatient and inpatient following the referral system. The payment mechanism is using the user fee system, which the country has already in place. The financing source for the CBHI schemes is from three sources, three types rather. The first one is from paying members, the people who can afford to pay contributes for CBHI schemes. And government gives targeted subsidy for indigent, for the poorest segment of the community, and also it gives a general subsidy. The most important three lessons, the lessons that I mentioned from the Ethiopia experience are, first, the supply side is very critical. So Ethiopia started by sequencing these reforms. Although the prepayment mechanism or health insurance was pursued as a policy, the government intentionally delayed its introduction. So it started with expansion of health services. Like when you see the number of health centers in around mid-2000, there were only 300 health centers, but more recently there are over 3,000, 3,500 health centers, which is a tenfold increase in number of health centers, which means increasing access. And likewise, the number of hospitals also increased substantially. From financing side, we started with increasing availability of resources at a facility level, like through revenue retention. Revenue retention is a policy decision that government made to allow health facilities to retain their revenue. In Ethiopia, we had the long history of paying for health. User fee was there when from the very beginning of having modern healthcare service. So around 2000, with health financing reform, it was allowed for health facilities to retain and use that revenue as additive to their regular government budget, which means giving to health centers more budget, and that accounts around 30% of their budget by now. So it's having 30% more money in health facilities. And then we also have a governance system in health facilities, which was very important in terms of making decision on the right time, including use of retained revenue for priority services. And the good thing in the governance system is a representation of community, local government, the health facility management, and also health workers. So it was a broadly represented board. The third lesson the second lesson, from Ethiopia is the role of government. As Nathan mentioned, from the list of lessons we learned from different countries, one important lesson is the need for government spending on community-based health insurance or any health insurance program, so that the poor can be covered. As I showed you, in terms of the financing source, government contribution in the form of both general and targeted subsidy was important. Additionally, government also hired three salaried staff to each of the CBHI schemes. Like now, when we see the 500 schemes, it means government is hiring 1,500 additional people for community-based health insurance. And the community-based health insurance schemes, they are not paying for salary. So any contribution, any targeted and general subsidy is being used only for paying for healthcare services. The third and last lesson from Ethiopia is the importance of organizational arrangement and having the capacity in place. One important structure that Ethiopia created or established is to have the Ethiopian Health Insurance Agency to lead the health insurance policy in the country. And in relation to community-based health insurance, it regulates, it supports technically the implementation of community-based health insurance, and it also advocates with government for budget and other stuff, and it's working on comprehensive legislation for community-based health insurance. Then at a regional level, Ethiopia is decentralized. So at a regional level also, we have strong structures in regional health bureaus having community-based health insurance team or a focal person, depending on the region. And then the regional health bureaus advocate for budget, for staffing, and other stuff. And then, as I mentioned, having the community-based health insurance structure itself at district level is important. And capacity building is critical, and that's what the most important thing that this project has been doing, and that is being transitioned in most cases to government. The Ethiopian Health Insurance Agency is leading the capacity building effort now. Thank you very much.
I put Gina on the spot, so I have to do the same to you. It's only fair. Okay, so I'm going to make a very public disclosure here. Hopefully it doesn't affect my career as a health economist. I'm skeptical whenever I hear of community-based health insurance schemes, right? You know, I have a lot of experience in Ghana, and I think about there were some really positive things that came about from a decade of experimenting with CBHI in Ghana. But as I mentioned earlier, after more than 10 years, they only reached about 1 or 2% of the population. Benefits were very, very limited, sometimes for things like snake bites and maybe one hospital visit. This is a very different story you're telling us about Ethiopia and CBHI. Is it the same thing? Is this the same CBHI? Or if not, what makes this so different, and what do you think is just really the most important things in this success that you've been describing?
Okay, I think that's a great question. It's good to discuss why community-based health insurance in Ethiopia. As I mentioned earlier, maybe it's good to start why community-based health insurance. The Ethiopian economy is dependent on the informal sector. So thinking about the social health insurance and not having coverage of the entire population as tax-based insurance, especially payroll-based insurance, will not be feasible in the Ethiopian context, was important. And I think the other important experience that we had in the Ethiopian context was to learn from other countries. Ethiopia took quite a long time in the preparation process. We learned it from all countries. I think we had delegations to each and every country, including Ghana, Senegal, which the traditional fragmented CBHI schemes were more abundant, and also Rwanda, where the community-based health insurance scheme was more government-led and robust. So we learned from those experiences and the policy decision. And there was that dilemma of having maybe one insurance program at one go, or having different programs, at least at the beginning, and eventually working on a unified insurance program. So the policy decision, and to be frank, also the technical recommendation for Ethiopia was to have two types of insurance, at least at this stage, to have a government-supported and including subsidized community-based health insurance, which in terms of even coverage, the 100,000, the average of 100,000 population is a relatively large pool compared to the experience to have in some of the West Africa and some of the East African countries. Like they were only for, or they are only for a small group of individuals who are relatively poor, small in pooling. So the Ethiopian pool was relatively large because it's district level, and then the government support, including the targeted subsidy, over 10% of the households are enrolled through targeted subsidy. So it's different in a way, but still it's community-owned. Community is active in the board, in the General Assembly, in decision-making, in the financial contribution, but government support is also there. So it's community-based, but it's not the conventional and traditional form of community-based health insurance program.
Thanks. Very interesting. And I just think really important points about, first of all, the learning from other countries. I hadn't known that part of the history. But then that role of government providing the subsidy, and you're right, quite a different size of risk pool in that scheme than others. Okay, great. So I think we have time to do the same. If there's maybe one burning question right now for Hailu. Yes, go right ahead.
I'm sorry. Tom Timberg, consultant. The thing that struck me is you had problems in Ghana with opposition parties. You didn't emphasize as much, but I know from reading the Indian press and so forth that the organized medical profession, different parties are very active. Is my impression that the political tradition in Ethiopia has been somewhat less activist. So perhaps it's your first point, basically. But if you have a less active politics, then you have to cope with it less. But I would raise one negative, which is it means that if anything is going wrong, the possibility for feedback is less there. There's less of an institutional group of people whose whole business is to give feedback, whether positive or negative. So I'm wondering if that's a difference.
I think that's an important question. In the Ethiopian context, when we see it now, I don't know if you are familiar about Ethiopia. We have political turmoil now. But what we hear from the people on the ground about the community-based health insurance is it's popular. Even in this political turmoil, even with this opposition, the community members are happy about it. So regardless of any political tension, it looks like the community-based health insurance is a popular scheme. Regardless of what type of political party, I think it will stay there. I know the Ghanaian experience, it started as a political movement, and eventually the winning party brought the insurance program. And it is there still in different parties. Once you have it, there is no way that it will go away. And I think the Ethiopian experience, it's more ground-based, and people are happy about it, and it will continue regardless of the political opposition and other political movements on the ground.
It's great. You heard it here first, folks. Once you have it, it's impossible it'll go away. Thank you very much, Haile. Okay, great. So we will now move to our third and final panelist and country case study. It's my pleasure to introduce to you my colleague, Laurel Hatt, who is a senior health economist with Results for Development. She has over 15 years of experience in health economics and finance, health system strengthening, and evaluation research. She has been the health finance lead for the HFG project at Apt Associates, and she oversaw a program through that role of technical assistance to over 25 countries, including strengthening financial protection systems, increasing domestic resource mobilization for health, strategic purchasing reforms, and economic analysis. And in all that bio, I didn't mention the most important point right now, which is she's been heavily involved in health system reforms in Indonesia. So we're very lucky to have her talking with us about that this morning. Please welcome Laurel Hatt.
Great. Thanks, Nathan. And lovely to see you all here today. Thanks for coming. I am going to shift gears a little bit and focus on the fifth lesson that Nathan outlined in his original presentation. And this is focusing on the importance, the critical importance of learning and adaptation as you implement a reform such as health insurance to expand coverage. Any massive reform that you want to implement is hard to get right the first time. And health insurance is one of the most complicated reforms you can possibly imagine. Indonesia is a context which took a pretty ambitious approach to this in taking on a big bang approach to reform, not a sort of incremental step-by-step approach to expanding coverage, but really trying to achieve universal coverage in a very short amount of time. So baking in that ability to understand what's happening with the reform and to revise it and tweak it as you go, that kind of real-time feedback loop is critical to ensure that a reform of this scale is successful. And implementation research is one approach to doing that. It uses rapid cycles of mixed methods, qualitative and quantitative research, to answer questions such as, is the initiative being implemented as it was planned to be? Is it leading to the expected changes? And are there unintended consequences happening on the ground? So why implementation research in Indonesia? Mainly because Indonesia itself is a very complicated setting, and because the insurance intervention called JKN is a very complex intervention. Indonesia is a huge archipelago, as you all know. There's quite a vast diversity, variability in the availability of health infrastructure and human resources across the country. And Indonesia has a very decentralized governance structure with over 500 individual districts with a significant amount of authority over their local populations. JKN, the National Health Insurance Program, was introduced in 2014 with this goal of trying to achieve universal coverage in just 5 years to cover 250 million people. And part of the complexity of JKN was that it was trying to combine multiple fragmented individual schemes, including social health insurance and programs for the poor, into one, and involving actors at the central level, at the provincial level, and at the district level in the implementation of this. So it involved just a massive new set of systems and rules and processes with great potential, as you can imagine, for both positive effects but also negative consequences. And so far, there have been major accomplishments in moving towards UHC in Indonesia. This is, on the whole, a huge demonstration of political commitment to health with this ambitious goal of reaching UHC by 2019. Government health expenditure has increased quite significantly since 2014 and even before that. And currently, over 96 million poor and near-poor individuals can access free health care. This number actually, I think, is a bit higher, over 170 million. I think it's almost getting towards 200 million individuals who are covered currently by the health insurance scheme. And there's been a significant decrease in the fragmentation of risk pooling as a result of this single-payer scheme. But there are also substantial challenges that have emerged. Probably the most noteworthy and the most of concern to the government of Indonesia is the rapidly rising costs in the country, and a concern on the part of health sector actors is that increased spending is not always going towards the priorities that were intended. So not going towards preventive care and focusing quite a bit more on hospital services and tertiary care. The provider payment system is not yet achieving the kind of quality of care that's been desired by the policy reform, and there's still a portion of the country, this missing middle that Gina referenced, in the informal sector, who have to voluntarily purchase insurance, and coverage is lowest among this population group. And this is overlaid over that backdrop of the diversity in the availability of health infrastructure and health workforce, which makes it quite difficult to achieve equitable results with a single payer scheme. So the HFG project supported a process since actually late 2014, after this scheme had been initiated, on implementation research for UHC. And we had 3 key objectives in supporting this implementation research project: to engage national and district level policy and decision makers in shaping the research itself and focusing the questions that were of a high priority to local actors, and committing to taking action on the results. Secondly, to generate evidence and learning from 2 rapid cycles of research that would stimulate that action. And finally, to strengthen regional capacity for carrying out the implementation research in the future on a more sustainable basis. And part of how we did that was by working through several different lead institutions in Indonesia. Our main partner was the Center for Health Policy and Management at Gadjah Mada University. They also convened the Indonesia Health Policy Network, and so we were able to work through that network with universities in different parts of the country, including North Sumatra, East Java, and Papua. And this is just a map of some of the sites where the different university partners were able to conduct conduct the field research. The experience in North Sumatra or East Jakarta is, as you can imagine, very different from the more resource-poor setting of Papua in eastern Indonesia. So just a couple highlights from the 2 cycles of research that we did. The focus of the research was in the first cycle very much on what the impact of JKN was at the primary care level, and specifically how the new financing arrangement, capitation, had impacted the provision of services at the primary care level. What we found in that first cycle was that indeed capitation had infused additional funds into the primary health care system. There was more funding that was flowing to that level, but it was not resulting in the kinds of improvements in performance that were hoped for. And that was partly due to the fact that the health facilities receiving these funds were uncertain about what they were allowed to do, what they weren't allowed to do with that money, how they could utilize it. A second finding from that first cycle was that the district governments and district health officials didn't also have a lot of clarity on what their exact role was in monitoring and overseeing and strengthening the implementation of JKN at the district level. So the existing health system is highly decentralized, and for traditional budget funding, local districts have quite a lot of influence over how spending occurs and how services are delivered. But the JKN insurance is a very centralized single-payer system, and the interface between these 2 systems was not very clearly elaborated in the initial rollout of the policy. So how the centralized funding and the local funding could work together to achieve the outcomes that were intended wasn't very clear to actors at the local level. So in the second cycle of research, we dug more deeply into the topic of capitation and why it wasn't working to improve performance and achieve the kinds of results that were desired. And the finding from this sort of deeper dive in the second cycle was that the capitation payments were not really tied in any specific way towards the performance of health workers and facilities. They were perceived more like a freebie, kind of like a top-up on top of the normal budget transfers and salaries that health workers received. And in fact, the capitation was resulting in a disincentive to hire additional staff. So this additional funding was coming in, but if you hired more staff, the capitation got spread into smaller pieces across additional staff. So there was an incentive to actually maintain a smaller staff so that you could keep more of that funding, which was clearly not the intention of the reform. So, of course, one of the objectives of implementation research is not just to raise alarms and awareness, but to try to translate those results into action and those tweaks to the policy or tweaks to the implementation that I mentioned earlier on. So can we say that that's happened in this particular process that we've supported through the HFG project? I think we can claim some results. It has only been a few years, so I hope that over time this process will achieve even greater results. But we can definitely say that as a result of this implementation research process, that both district and national level policymakers have a clearer sense of the on-the-ground implementation challenges, especially associated with capitation and it not working quite as expected. We're really excited that there's going to be a new presidential decree or a regulatory reform that's going to be released in the next couple of months, we understand, that will clarify a number of revisions to the policy, and part of those will be to better tie payments to the desired results and clarify the rules about what health facilities can and can't do with capitation and how to ensure that the allocation of those payments is stimulating better performance. And I think the third major outcome of this work is a really greater recognition of the need to bring health sector actors together at the decentralized level, at the district level, and that there has to be an intentional process to allow that centralized level to interface with actors at the district level where the action is taking place. So in some, whenever you're thinking about expanding coverage, clearly there's a number of technical level lessons that are very important in the design, but having a process that allows you to understand what's actually happening on the ground and make changes in real time is really critical to ensuring that the reform is achieving the results that are desired. So massive reforms, they're hard to get right the first time, especially if you're doing them in this very kind of big bang approach. But implementation research can allow policymakers to get it right faster. Thank you very much.
Thank you.
I'm just going to stand here.
Thank you very, Laurel. You've all now learned the rules of the game here, staying there. So thank you. So I would like to ask about the universities that you mentioned. That struck me a bit about the role that they played in implementation research, partly because it contrasts with some experience that I've had in Ghana, where that role is kind of tightly held within a research directorate in the National Health Insurance Authority. So I guess the question that leads to is, what are the best institutions to lead this kind of implementation research? Why universities in Indonesia? And I'm sort of guessing that, maybe there are technical pros and cons, but it must also be a bit of a political kind of decision to make who has that role. So can you say
absolutely.
a little more about that?
And we did a lot of thinking about this in the initial design of this work. And at the outset, we did a landscape analysis to look at the different institutions that are available within the government, as well as the capacity at universities. The advantage of going with a more academic setting to be the home for this kind of research is that you get that neutrality, that sort of independence from direct government influence, potentially, over what results get shared, how the results get shared, and so forth. The disadvantage of working through academic institutions is that they're not the implementers themselves. They are one step removed from that, and they're channeling information back to those who can make the changes. We thought about working with the unit inside the Ministry of Health that does this kind of research. They honestly at the time that we were doing this, did not really have the capacity to take this on. And I think there was some concern, actually, some sensitivity, that if they took it on, they might not be able to have the independence that was necessary to really to say publicly what needed to be said about things that weren't working. So what we did was establish a steering group that involved the Center for Health Financing within the Ministry of Health, the Department of Planning, the Ministry of Finance, and a number of other national level stakeholders, as well as representation from the districts where we were working. So we had a very engaged process, a very iterative process from the beginning in the selection of the research questions that were of highest priority, and then in the feeding back of the results to stakeholders, both through one-on-one consultations and then in large group settings and webinars and lots of different fora. So there were multiple opportunities to feedback and share those results. And I think actually our university partners, they were very excited to be able to engage directly with the district governments in the places where they were identifying challenges with implementation, because that was where they could help to establish some of those local platforms for taking action as a result of the work.
Excellent. Thanks a lot. Really interesting. And I'll have to quiz you more later about the steering group, particularly. That's, it's just one of those things that it's a role, it's an institution, if you will, that didn't exist before, that clearly was necessary. Okay, great. So I think I saw a hand over here. Maybe we can have one question for Laurel, and then we're going to go to a broader Q&A. Please.
Actually, this is for anybody on the panel who'd really, really like to answer. I'm sure all of you would have great contributions. My name is Christine Ortiz. I'm a senior technical advisor at URC. I, too, am passionate about health financing and could talk about UHC forever. So this to contribute to the discussion. As international health professionals, I think that our goal is to work in decreasing financial hardship and increase well-being of people. These people are politicians, these people are healthcare workers, they are patients, but then there's also all these people who will contribute to risk pooling through either taxes or payroll taxes or other things. And their expectations are very important in the success of the rollout of any universal health coverage scheme, right? And Gina touched on the middle, and Hailu touched on coverage of the poor, but do you have any specific examples of how to take these expectations into consideration in the planning for implementation of UHC?
Expectations on the part of different
People.
social actors.
Does it fit into your lessons learned in the political?
Actually, I think Hailu might be best to answer that. I mean, I can speak in a generic term, but I think the Ethiopian case might be the best place to respond to that specifically.
Yeah, I think understanding the expectation is very important, and especially when you introduce insurance and when you ask people to pay for it, regardless of what type of source of payment they have, be it payroll or contributing from their informal income. What will they get out of it is very important. So in Ethiopia, I think the service readiness is very important. So we included intentionally readiness of facilities to meet expectation of especially members of CBHI schemes. When we piloted CBHI, we had rapid assessment of the health facilities in those CBHI districts and make extra efforts, mobilize extra support in terms of budget, in terms of equipment, availability of inputs into the facilities so that CBHI members, beneficiaries would get what they expect. And that is a practice even afterwards. Now we have 500 schemes. So in each and every district, they do rapid assessment of facility readiness, and they make extra efforts to make facilities ready. And I think after that, what is important is we have facility governing boards in each health center and hospital, and we have community-based health insurance boards. So we also somehow, it's being practiced. We created that interface between the CBHI schemes and health facility, be it boards or managements, to make sure the client feedbacks and expectations are feeding into the health system, the health facility management, and keep the quality. And I think because even the CBHI, the revenue from the CBHI schemes, like Laurel mentioned, the problem of using the capitation money. I think in the Ethiopian case, we have that well established through the RRU system, through the revenue retention system, and how to use the retained revenue is clearly defined by law and clearly also defined in the operational guides. And then the expectations are even better improved through additional money coming through community-based health insurance program. So yeah, expectations are very important, and we take them into account.
Yeah, and I think you're right, very much a political and technical process, a good example of that. Yes, and I just want to say, well, I just sort of want to formally end our, what we're obviously doing here is formally ending our panelist session. And just to let everyone know, we have lots of time now. We are interested in your questions, your comments on any of the presentations. And I told you, I gave you an assignment at the beginning of the presentation. We also want to know your thoughts and your experiences, perhaps we've only sort of talked about 4 countries here, your experiences from other countries. So the floor is open. I'll moderate a little bit. So let's go ahead. Gina.
Maybe just to, thanks for your question, Christine, just to build on, Hailu's comments about facility readiness and so on, but in terms of planning, but also, early stages and ongoing, your comment made me think about the importance of just education and helping people who may have never had insurance begin to learn about what it is and also, importantly, what it isn't. So, if I'm covered and I have a card, does that mean I can give it to my neighbor when my neighbor is sick? Does it mean that it will pay for every service imaginable and I never have to pay? So I think that importance of aligning expectations is one that is ongoing, and I think the importance of building trust is fundamental to people understanding, what their entitlements are, and then just how even to use insurance. If I know if I have a certain entitlement, but do I have to submit a claim? How do I do that? Where do I pay my premium? All of these different stages can create a loss of trust and create a situation where the outcome that the insurance product is intended to produce isn't achieved.
I would just add also another case to maybe look into on this question that I find very interesting is Chile's experience with their AUGE reform, AUGE, which is for universal access with explicit guarantees. When they started that, they had a problem on their hands. It's the one you're raising. How to deal with population expectations of what benefits they would like, but also balancing what revenues they would be expected to be able to raise and what the costs of services are, right? That is the square peg into the round hole challenge that they had. Their, I think, quite politically savvy move in that case was to say that they're not going to change what package of services had been provided before. It had not been explicitly defined. They said FONASA is still going to cover everything that FONASA has always covered. But we are going to prioritize this small set of services that we think are so important and that we know we have enough money for, and we're going to grow that over time. And that is what they've done. They started with a package of, I'll forget the number now, but it was like 12 services. And they did the financial analysis that they could afford it. It matched burden of disease analysis. It matched social preference survey information that they had taken. And then they have redone that analysis every few years and have grown that package to, I think, over 80 services right now. So it's a interesting case of trying to balance the different pressures there. Okay, great. Another question? Great.
Hi, Catherine Connor. User fees get a bad rap, there was years where there was a lot of pressure, political pressure to remove them and offer free care. But maybe what's part of the success of introducing and expanding health insurance in at least 3 of these countries is that the population faced user fees. And so it's like, there's a thing called insurance, and if I get insurance, then I won't have to face the user fees when I need care. So just an observation, and I wonder what do countries do that their official policy is free care in the case of Uganda and Liberia?
Yeah, I was going to say Liberia is facing that challenge right now.
I'm just repeating the question. And now I'm holding the mic. Bob.
It's Bob Fry. I'd like to sort of follow on that. There was, and also, if I may ask a quick question, then we should probably go to online. In response to that last point, there's a very interesting, the UHC forum took place last week, the World Bank USAID UHC forum, and there's a very interesting presentation by Joe Cutzin about Sri Lanka. And so who haven't followed any of the rules and actually have universal health coverage and don't have any of these financing or reforms in place. And I think the point is that countries are all different and gone down different paths, and you build on what the past. So in countries that have had lots of out of payments, then obviously insurances are going to be a massive step forward. But in countries that haven't had it, then there's maybe a different path that's going to come along. So that's just a response to that. But before Laurel takes it, I'd like to get my question in, because in case I don't get the mic again. Something else that came up last week and that we hear about, and it was alluded to in the presentations, is about how the revolution of digital technology is sweeping over countries. It came up a few times in your presentations, but could you maybe the panelists say a little bit more about that? Is that are countries looking to the future and seeing massive opportunities with the digital revolution, or is it a bit of trepidation and fear and concern about what to do? And maybe you could just sort of comment on that. But back to you.
So maybe I'll let someone else answer the digital question. But just as I was trying to gather my thoughts in response to Catherine's difficult question, maybe we need to frame the question a little bit differently. Because if a country currently has a risk protection system that adequately provides free care, and that's being adequately funded through taxation revenue of various types, there may not be any need at all to transition to a contributory-based insurance system. So we shouldn't assume that going towards insurance is the only model that makes sense. Free care, the question is there actually free care being offered? Is it of adequate quality? Is it accessible? Is it truly free, or are there a lot of associated costs that are being hidden? And I think the challenge is that the approach needs to be focusing on what a new system could deliver that's better than what exists currently. And if what exists currently is in name free care, but it's actually of wretched quality, then people might actually be willing to start paying for something that's better. So I think that's partly how we want to frame the conversation.
I think to add a small point on that, user fee could be free in policy on paper, like you mentioned the case of Uganda. In Uganda, household out-of-pocket spending accounts around 41% of the total spending. Okay. And also the most important thing in the case of Uganda is also the most of that out-of-pocket spending is happening in public facilities. So it is free, but is it free? So in that case, I think any type of insurance would make sense. But in other countries, like we have Botswana, we have Zambia, we're working on, and it's a challenge in some of the countries if services are provided. But the other issue is, are those services appreciated by the public, or are they going to private providers, and anyway householders are incurring user fees?
Can we take a couple of questions online?
We have a question from Donald Shepard from Brandeis University. He asks, for those in the informal sector in urban areas, how do the schemes identify poor people who deserve subsidy compared to those who could afford to contribute? And is there outreach to poor people to encourage them to request subsidy?
Thanks. I can start on this one. In India, there have been a number of different ways to assess and try to identify who are poor people. The most commonly used mechanism, they refer to people as being below the poverty line, and you get a designation, but that is, I think, oftentimes disputed. I mean, people who make a lot more money somehow get a card, and people who deserve to be designated below the poverty line don't have the card. So the system hasn't worked very well, but that's maybe the most common one, and in fact it's the one that the RSBY system relied on. There are other systems that are more accurate, they're more costly, but where they're based on household surveys and looking at things like, is there a motorcycle, or what type of plumbing fixtures do they have, and just a bunch of questions that can make a more true representation of whether that is a poor household or not. But it's difficult, and frankly, I would just say in the research that HFG did in India, I mean, the estimates were between something like 13% and 35% of people in cities could be considered to be poor. So I think there's an opportunity to come up with more kind of accurate and efficient ways of measuring this.
I would add, both to underline the importance of the question, I think part of the answer is that it's very difficult to do. In Ghana, the original National Health Insurance Scheme intended to charge a graduated scale of premiums depending on income that people in the informal sector has. They quickly had to abandon that because there was just no good way, particularly when this was run at the district scheme level. There was just no good capacity without a formal, very extensive formal tax system to identify income. And even those that might have been identified as having much more wealth, let's say by household features, or they owned cattle or something like that, often those people were responsible for much larger groups of family members. And by spreading out that wealth, they were essentially the equivalent of poor. Very quickly, everyone started paying the same premium. The only kind of resolution that I might suggest from the Ghana experience is to recognize that this is hard enough that it is worth unifying efforts to identify people across different government programs. Because there are many, not just in the health sector, that have a desire to identify such populations. Ghana has made some progress with this. Their primary poverty reduction program that's called LEAP, through a few years of dialogue, ultimately all the various actors from different programs, education, health, nutrition, et cetera, have agreed to really let LEAP run that. And now, to get a poverty exemption from NHIS, they defer to you being a LEAP member. So it's actually had a nice benefit of strengthening the LEAP program and also having at least some efficiency in the work that goes into identifying people.
Just to add in on the Indonesia experience as well, I think a lesson that you could draw reflecting what you just said is that trying to do poverty targeting inside of the health sector can be very difficult, and it often makes sense to do poverty targeting on a national basis outside of the health sector because because subsidies are needed for multiple social programs. In Indonesia, there is also a unit that does poverty listing, basically, and keeps a national, I'm forgetting the exact terminology, but a universal database of everybody in the country based on the census and then updated with some regularity that involves asset testing and a registry of all the households who are considered to be in the different poverty groups, the poorest third, the poorest quarter, and on downward, and different groups are eligible for different subsidies. There's a lot of challenges with keeping that registry up to date, and with leakage, and with people in urban slums, for example, transitioning in and out of poverty, who aren't able to access the free, completely subsidized health insurance that the Indonesian system provides. There's not an easy solution to that, but it's at least there's a systematic attempt to approach it in a consolidated way.
Great. So we also had a bit of a conversation going on online around CBHI, and I wanted to get your thoughts on it. So someone was discussing if CBHI schemes are only viable with massive subsidies and given their high admin costs, what is the point of them if they're not making any net contribution to funding health services? To which we got a response around it's better to have CBHI than nothing, given that 80% of the informal sector is not taxed in such countries. And so where would the taxes come from? So just any thoughts on that?
Reassures me that I was right to ask my skeptical question of Hailu. But also, I mean, with a lot of these things, whether it's do you use user fees or not? Should you use CBHI or not? I don't mean to sound simplistic, but the first step, I think, in answering a lot of these questions is that there is not a right answer. And I personally would be quite skeptical about answering many of these questions in any kind of black and white way. User fees, in South Africa, the Department of Health was vehemently against them. National Treasury definitely wanted them. They came to somewhat of a consensus, I think I can say, that they wouldn't view them as a primary source of revenue. Don't use user fees as a primary source of raising money for the system, but leave the door open that maybe they're needed to influence pathways of care and get certain efficiencies. Maybe that is an okay use of them. It's just one of these examples. CBHI has all these well-known limitations, but perhaps it's the only option to cover large groups of people in Ethiopia in the short term, and maybe it serves as a stepping stone to a different way of purchasing health services, guaranteeing access. And when Ethiopia faces the problem someday of merging it with the social health insurance scheme, they'll face that problem that day. Hailu, would you add to that?
Yeah.
Oh,
Yeah.
And maybe I don't know if you can add on Bob's question.
Yeah, I will touch a bit on Bob's question and also on the issue of urban poor as well. I think on the administration cost and the cost benefits of having community-based health insurance scheme, as I mentioned earlier in the Ethiopia case, although it's community-based, the pool is relatively large compared to the conventional CBHI schemes that we know. 100,000 population is relatively large, but still the cost of administering that is not that easy, and it's a learning process, and also it's more to think about how to go about consolidating the pooling system. And Ethiopia is working on like a sub-national level pooling and eventually even a national level pooling. And then merging all the insurance schemes like social health insurance is still, it's under process. So the long-term plan is to have a unified health insurance program, then that administration cost will maybe reduce, but eventually you need also branches across the country to administer, even if it is one national health insurance program. So some of the cost will remain there, but certainly most of the cost can potentially go. On the issue of the urban poor, I think it's not only the urban poor, but even access to service, especially to hospital services, much better for the urban population. And once you enroll people in CBHI scheme or any insurance, the health service utilization will substantially increase, and the revenue and expenditure, the revenue and the cost needs to be balanced out. So there is a need to work on that. We learned from the Ghana experience. And in the Ethiopian case, we are piloting it in Addis, the largest city we have in country, to see how community-based health insurance can function in urban settings. That will include definitely targeting of the poor in urban setting. And the other issue both Laurel and Nathan mentioned is to work with other national poverty-related programs. Now, even for the broader community-based health insurance, we are working with the Ministry of Labor and Social Affairs and UNICEF, which they have a a national safety net program for the poor. So we are using or working towards using the same targeting strategy to have one national targeting mechanism of the poor, and then use that for subsidizing for community-based health insurance enrollment of the poor. The issue of digitization, I think, is very important, especially in very fragmented community-based like structures, and given that the mobile technology is spreading very fast. And in the case of Ethiopia, we are working on that. It's just at initial conceptualization stage. And the good thing is government is also working on use of data and digitization. And I think eventually digitization will be important, one, for messaging, reaching more people in the community using digital technology. The other is enrollment of households into a district level scheme. As I mentioned, CBHI schemes don't have village level structure. So digitization would facilitate that link with community level structure, and then paying through mobile technology, and also even paying for service providers from CBHI schemes using digital technology or mobile money would be very important. So digitization, I think we need to work more on that, and it will be a very helpful process for community-based health insurance, or generally for health insurance.
Thanks. On, sure if the mic's working, the digital question, digital technology, again, just reflecting about experience in India, but in many places, Kenya and around the world, in fact, now, where technology can increase the efficiency of insurance functions, and really be a help leapfrog to create greater financial inclusion. So for people who don't have bank accounts, for people who may be illiterate, who may not be formally registered in the country. So through the use of the mobile phone, this can sort of overcome many of those obstacles, and at the same time, using digital technology can reduce the cost of delivering health services. So I would make a plug for what I would refer to as telemedicine, call centers, ways for people who have mobile phones but may have difficulty to access healthcare services because of their opportunity cost to travel and so forth, to find ways to integrate more of those services, because that's a way of improving the sort of client satisfaction and reducing the cost at the same time. I think one of the statistics that sticks with me is that some 70 to 80% of inquiries to a call center can be resolved with the phone call, so that the person doesn't need to go in and actually seek care with a provider.
Nathan, we got a question here.
My mom's a nurse practitioner, and I use that feature with her. Over half the time, I don't need to go in. That's fine.
Okay, thank you very much. I just wanted to have a quick plug as well for the CBHI in Ethiopia regarding the administrative costs. Some of the things that are being covered for Ethiopia are using existing structures as well by the government. So especially at the sub-village level as well as the district level, already existing structures are being used. That brings me to the second point that I wanted to make, and related to the lessons learned. How do we go beyond this traditional labeling of CBHI, SHI? Because sometimes what we see is a hybrid. The case of Ethiopia is showcasing that, because it is semi-autonomous, it's community initiated, but heavily government supported. So how do we get beyond that traditional labeling as well? That type of lesson should be part of this as well.
Great comment, thank you. Should we go to another online question?
Yeah. So we have, this is from Rob Yates from Chatham House, and apologies if you've kind of already gone over this, but this is specifically for you, Nathan. He says, given the unsatisfactory record of voluntary health insurance covering the informal sector, including in the U.S., would you agree that if developing countries want to reach full population coverage, they'll need to use predominantly tax financing to cover the informal sector?
Yes. I agree. Does anyone want to? Do we all agree?
I think we all agree. I think it's lesson 2. I mean, government
Yeah, yeah. I mean that is. I think that's one of the reasons we highlighted that. Is it lesson? Yeah, 3. That this is, again, I would crack a door open a little bit to say that in particular contexts there may be reasons. I mean, we just heard Ethiopia. It's voluntary enrollment, right? You have voluntary enrollment, but people are not paying out of pocket to enroll. They are. Some of them are.
They pay,
Yeah.
but you have targeted subsidy for them.
Yes, right. So, you have voluntary enrollment. You have not 100% government subsidy. And we know that there are some problems that come for that. Anytime you have voluntary enrollment, especially if there's a cost involved, you may have people that are at greatest need for health care, and especially if they're poor, are least likely to want to go and make the effort and prepay for this package, and they're more likely to suffer at the time when they actually need health care if they do not have that coverage. On the other hand, this is a program that is part of a larger health financing strategy as Ethiopia is trying to get to universal health coverage, and there's been some major successes so far in covering large amounts of the population with services that they now have better access to, a little bit better financial risk protection. That's a bit of caveat language, but the first thing I think we all said still applies. We would agree. Yes.
Just speaking on the Indonesian context again, Indonesia is facing exactly this challenge of this missing middle of the informal sector. But they've very impressively already expanded coverage to over a third of the population through tax-based financing, through general revenue subsidies that come from the national budget. And then another substantial chunk of the population, I won't give figures because I don't have them at my fingertips, but the upper income portion of the formal sector economy contributes through payroll taxes. So the chunk that's missing right now are those who don't fall into either of those categories, who are not in the formal sector paying a payroll tax, and not in the poorest third of the population receiving a direct subsidy. The current strategy of the government in Indonesia is to use voluntary premiums, and they're having a lot of trouble. There's a lot of challenges trying to achieve universal coverage. I think there's some tacit acceptance that they probably are not going to make this ambitious 2019 goal because of that last chunk of the missing middle who voluntarily may not enroll. But that's a political decision on the part of the government, and it's related to the financial constraints that the government faces right now. There was discussion prior to the initiation of this reform of covering the entire population through subsidies, and it was not thought to be politically tenable at the time, given the macro-fiscal constraints of the country. And I think the approach now is to hope that the country will grow economically, that the formal sector will expand, and if the financial situation changes and a larger proportion of the country can be covered through tax revenue financing, that can be discussed in the future. But it's an outstanding challenge in that country.
We have one question here in the room.
This is very specifically on Indonesia. You mentioned that you were going to get a Kepres, a presidential order in the next few months, but you also identified the fact that the actual controllers of the health centers didn't have much of a direct connection. Have you also explored how you will link the Kepres, the presidential order, to getting any sort of response from the health centers. Who does control their budget? Who does control their hiring? Is it the Kapaladesa? Is it the person who's in charge of the so-called regency, the district? Is it the who? And have you identified that? And how will you make the or how will anybody? It's not you. It's presumably, I hope, Indonesians make the link between the order and getting the local health providers to improve the quality and I gather to some extent it's volume. There's hire a few more people.
That's a lot of questions all wrapped into one, and I cannot claim to be able to answer all of them. But the new regulation is something that will be decided and defined at the national level and then disseminated downwards through the Ministry of Health channels from ministry level to central level to provincial level and to district level. I understand that there will also be some dissemination of regulations through the National Health Insurance Agency, which also has a central level, provincial level, and local branches as well. But your larger point of how do central level messages get communicated down to the local level is a very challenging one. And that's exactly what we were investigating in the implementation research, is the fact that the technocrats at the central level, defined the legislation around JKN and issued a number of regulations to clarify its implementation. But providers, managers at the puskesmas, the local clinics and the local hospitals, there was a lag in the time, in understanding exactly what their roles and responsibilities were. And not every single tenet and facet of how they should operate could be defined right at the beginning. So there was a lot of experimentation, a lot of uncertainty about what they were allowed to do, what they weren't allowed to do. And the presidential decree process, I think, is actually intentionally meant to sort of iteratively update the regulations to clarify where things are not clear in terms of how providers are supposed to behave. So we hope that at least in part this implementation research process that we supported, which was, in a small number of districts, it was in 5 districts out of 500, so clearly not trying to capture the entire experience of the country, but that at least these sort of sentinel experiences could be translated upward in a more direct manner. We were sort of leapfrogging the multiple steps of the bureaucracy and the hierarchy of the decentralized governance to try to share some of that very local experience to the technocrats at the central level so that they could make the necessary changes to improve implementation.
I'm starting to look at our timekeepers, but maybe wondering if we have time for at least one more online question.
Yeah, we have one clarifying question for Hailu. This is from Gasper Bokaro from the University of Malawi. How are the premium household payments designed? Do they reflect the ability to pay for those who are not subsidized? And are the beneficiaries targeted using wealth-based measures?
Mm-hmm. I think to start with maybe the second part on targeting. So far the targeting was done through community identification of the poor, because we are talking more about the rural setting, and the communities know who is who in the community. So they have the wells and other criteria to identify the poor for targeting, and then that would go to the village level administration for verification and validation, and then to district level for final approval and budgeting. So that's how the targeting goes, targeting of the poor. In terms of the premium or the contribution from households, yes, ability to pay, willingness to pay of households is taken into account, and especially when we piloted the community-based health insurance in certain districts. We had a thorough feasibility analysis, including willingness and ability to pay of households, and that served as a basis for the setting the contribution for the piloting. And then we had evaluation at the end of the piloting, as I mentioned, in 2013-14, and that showed in some districts the contributions were not enough. So it is standardized across the country, across all CBHI schemes, and it has been raised a bit upwards because it had to be adjusted to reach the need, and also utilization through the pilot. We also learned that utilization was much higher than we initially thought. So yeah, willingness to pay, ability to pay was taken into account, but also cost for providing service was also another factor.
So I think it's time for me to say thank you on behalf of all my fellow panelists. It's been a real privilege sharing our thoughts with you on this topic and listening to your comments and questions. Just a special shout out and thank you to all of you who joined us online, and I think probably offered some comments and such that we can even view after this. Really appreciate the questions. Sounds like they came from a good distance across the globe a little bit, so that's neat. And I will turn it back to Catherine to close. Thank you.
Okay. All right. I just want to applaud all of our panelists and a great moderation by Nathan. Thank you. And also wanted to thank our communications team, Jen and Alina, Stephanie and Rachel, for all the logistics to pull us all together successfully today, and everything worked, right? Yay! But most of all, I want to thank all of you that you coming here in person and everybody online. Really excellent questions. I mean, it's just a really fascinating topic, and I think it's so particularly interesting that you get. I was just checking on my phone. Ethiopia at about $860 per capita GDP, and India double or more than double at $1,900. And who's going to get there first? It could be Ethiopia, right? It's like it really matters what you do with these policies and these designs and what process you use, because you know, even if you don't have as much money, you could make a lot more progress than other countries. So I think it's, I think these kind of discussions, that's why they're, yes, no, present company acknowledged. But if for those of you here, please grab a copy of this brief on health insurance, and for all of you online, we have this brief and the many others all available on our website. And also for those of you who are in the Washington area, we really would love to see you at our end of project event, which is on May 10th, Thursday, May 10th, at the Ronald Reagan Building. So thank you, everybody.